Easy to align the plate to the shaft and then to put the screw. Do you have some trick to tell us?
Thank you very much, Dr. Leo, for your interesting question. Frankly speaking, we observed that we have some problems with distal positioning of the plate when we use a limited but open delta pectoral approach, because it is really hard sometimes to put the plate laterally, because the approach is in the sagittal plane itself, but you need to put a plate perpendicularly to the approach, and it is difficult. But on the other hand, when we use a lateral approach or anterolateral, then it's much easier, because the plane of the approach and the plane of the plating itself, they are collinear. They are in one plane, and that's why we make, when the patient is skinny with a low weight, we can do it even percutaneously, but when she has more obese or overweight, then we use a small incision like 1 centimeter and just align it on the image intensifier. But really it is, we regularly, if a patient has a normal weight, we do not need the approach bigger than that. We even sometimes do a smaller one, but sometimes there are no people to make a picture. So,
another question, please.
We know from several studies that biomechanically the C and D row on the locking plate is very important, the screws, because this is protect the calcar and the medial. And without any dissection of the axillary node, how can you put your C and D row screws? And the second question is, I see from your X-ray, and those are there in their group also medial part involvement in your case, and how can you restore the medial part without using the C and D row?
Okay. Thank you very much. Thank you very much for the interesting question. I must admit that really in the maybe in the literature, like 5 years ago, it was a huge discussion about this calcar, so-called calcar screws that you put through the D row. But in reality, the latest studies, they really don't show any difference if you put those screws or if you do not put it. Much more important is the reduction you have. And if you have a valgus type fracture, I think Dr. Neer, Professor Resch will support my idea that if you have a valgus type fracture, then you can easily, in most of cases, reduce it by close manner, and the quality of reduction is really on the first place, and not the number of screws, and even not the type of screws, because I think that we all know that the most strong bone is the upper and posterior quadrant, but not the lower one. And in this series that these patients are included in my PhD study, I have not seen the difference when we put the screws via delta pectoral approach and when we don't put it via anterolateral approach. If the reduction is suboptimal and not so good, and the bone is osteoporotic, it will have a varus collapse, and the screws will penetrate no matter what. So this is the answer for the first question. And can you please...
You have to carry on with it, please.
Yeah,
can you give a short answer?
And please specify the second one, because I did not grasp it fully. Okay.
In conclusion, you recommend this anterolateral approach, and I congratulate you because you have any axillary nerve lesions in this large area. It's brilliant, and thanks very much.
Yeah.
We have to carry on with the last 4 papers.